microscope. How or why the protein starts misfolding, we don't really know, but this abnormal protein is believed to be toxic to neurons, and then once that neuron dies, it spreads to others. There's a new theory going on that it kind of starts in the gut and then goes up to the brain, but it's not exactly known even how that starts up. So what are the symptoms of Parkinson's? So we divide them between motor symptoms and non-motor symptoms. So the motor symptoms most people know about. So classically it's the tremor, right? But it's a rest tremor, much more than an action tremor. So it's more predominant when you're sort of just letting your hand rest there. And then as you move it, kind of goes away and then comes back again. The other thing people notice is slowness. So that's so-called bradykinesia. Some people, think about this as, weakness per se, but if you test them, if we do a confrontational testing, we ask them to squeeze and push, the strength is there, but it's a sort of coordination and it's perceived as weak and it becomes slow. You can see this in, people's faces. They have that blank stare because they have a loss of decreased facial expression. Sometimes people have the decreased arm swing, which some people notice. That's all part of bradykinesia. Then there's this rigidity, so idea of stiffness. Varies patient to patient. Some patients don't really notice it, but on objective exam, we see it. But some people do notice, from spasms or just difficulty moving as to how it feels. And there are gait changes as well. This usually happens much later on in the disease, but early on, people may feel like my walking is a little slower. Again, the arm swings change, it doesn't move as much, which goes with the bradykinesia. However, there are also multiple non-motor symptoms as well. So there are psychiatric symptoms such as depression, anxiety, apathy, so loss of motivation that may not be related to feeling sad at all. Some people can become impulsive or compulsive, frank hallucinations, delusions, so psychosis. Cognitive changes occur. So people most complain about memory and mostly short-term. Sorry, can someone please just mute themselves? Sorry about that. So memory change, a lot of people will complain about, word finding difficulties, searching for names, searching for words of objects, or, just even events. And then when they're cued for it, it comes back to them. You can complain of slower processing speed, some decreased concentration. Dementia can occur usually much later on in the disease, however. GI dysfunction, so autonomic dysfunction. So autonomic dysfunction is something we think about your nervous system. So there's things you consciously think about and things you don't think about. So things like your blood pressure, going to the bathroom, those are controlled what we call the autonomic neurologic system. So people can have manifestations like in the GI tract. So constipation is a big problem, as many people know. Cardiovascular can be issues like most prominent would be what we call orthostatic hypotension. So this idea of feeling lightheaded when we stand up, your blood pressure tends to drop. Normally your blood pressure would increase so that your blood doesn't drop all the way down to your legs. But this response is blunted in Parkinson's. There can be genitourinary problems, so urinary urgency, frequency, erectile dysfunction. There are other things like people can complain of temperature changes or intolerance, like I'm too much sweating or I'm too cold or drooling. Sleep disorders are very common as well. So insomnia, excessive daytime sleepiness, fatigue, something called REM sleep behavior disorder. So this is disorder where, when we're sleeping, evolutionarily, we're supposed to be paralyzed so we don't, act out our dreams or hurt ourselves. This is blunted in Parkinson's, so people can act out their dreams, jump out of bed, kind of look like they're fighting. And then there are various sensory changes. Anosmia, so decreased sense of smell or loss of sense of smell is very common. It's actually sometimes one of the earliest signs of Parkinson's disease. Sometimes there are some weird pains involved, visual changes, including double vision, difficulty with what I call convergence, so your eyes coming together when you're reading. So there, as you can see, it's a multi-system disease. It affects many systems. But the problem with non-motor symptoms is also they're very non-specific, right? So it's hard to say absolutely everything is due to Parkinson's. So how do we diagnose Parkinson's? So Parkinson's is primarily a clinical diagnosis. That means that we base a neurologist or a movement disorder neurologist, with their expertise, based on your history, your exam, and exclusion of other diseases that have similar symptoms. So that's how we take the whole picture, and then we come up with the diagnosis. There's no laboratory test or imaging test that can diagnose or confirm Parkinson's. Some of you may have heard of DAT scan or a SPECT scan, which is a nuclear study and looks at dopaminergic cells, but it can't tell the difference between Parkinson's or other diseases that cause cell loss. So say if you had a stroke in that area, that test would still be abnormal. So that's diagnosis. So it really takes expertise, good history, and a good exam to make that diagnosis. So moving on, let's talk about treatment. So mostly when we talk about treatment and all the myriad of medications out there, really talking about motor symptoms, right? So before we even get started, let's do a little biology. So here, there's a schematic of a neuron. So neurons communicate to each other using electrical and chemical signals. This message is generated in the cell body. So if you hear it, look on the far left, this area with the nucleus, this is the sending neuron. This is the big body. And that's where the message starts. And then it goes down, so the railroad track, so this is called the axon, to the next neuron, right? Now, once a message travels down the axon, this is traveled by electrical impulse, and this becomes a chemical signal to be released and sent to the next neuron. So basically, that they become chemicals. They need to fuse with the end of one. We could call this another Waylay station, and once this membrane fuses with the end, it binds to the next neuron, sending the signal to the communication to the next cell. And if you have questions about that, we can discuss it in a little more detail. But generally, basically, all you need to know is like we have a station that goes onto railroad tracks, and then you need to send the package to a delivery man to take it into the next station and send it to the ongoing cell. So when we're thinking about pharmacologic treatments, we're basically trying to work with this system. And the main thing we're doing is augmenting dopamine, right? Because that's the messenger, or that's the chemical that is most affected in Parkinson's. So we're going to go more into this detail, but so there's dopamine. So basically there are 4 ways that we go about it. One, and we're going to do each one separately. So one is dopamine replacement. So that's just to replace what you're missing. And so we can say here on the far left, so there's something that replaces dopamine. There's things that mimic dopamine. There's things that slow the metabolism of dopamine. And then there are other drugs that can work on the balance of other chemicals so they can boost dopamine. I'll go over each one in detail. So let's just talk about dopamine replacement. So this, as most people know, is levodopa. So levodopa is a precursor of dopamine, which gets converted to dopamine once it's in the body. Although we call it a medicine, like you call levodopa medicine, it's actually a naturally occurring amino acid that we all take in our normal diet, albeit in much smaller concentrations. So it's in things like bananas, fava beans, and other broad beans, and something called mecunopurines. You can think about dopamine as like you're basically using vanilla extract. So it's like, but obviously what we eat is not in the same concentration as I give you in a pill, right? So you can think about what we're doing is taking the strongest dopamine, purifying it, and giving it to you as a medication. So think of it as a pure vanilla extract in a way. It is still the most effective medication for Parkinson's motor symptoms by far. Now, people get confused because it's always in a combination of carbidopa and levodopa. Levodopa is the active ingredient. That is the medication part. But it's always in combination with carbidopa because it slows the breakdown of it while it's getting into your gut. And it reduces the nausea that occurs when it's being broken down in your gut. There are a variety of formulations out there. So these are Cinemet, our standard carbidopa, levodopa in immediate release. There's the old form of Cinemet, CR, ER, so carbidopa, levodopa controlled, aka extended release. People may have heard of Stalevo, so that's carbidopa, levodopa with another medication called entacapone, which also slows down the breakdown of dopamine. There's Rytary, which is a new carbidopa, levodopa extended release capsules, and there's of course the newest one, Embrita, the inhaled levodopa. This is the only one that does not come with carbidopa, and I'll talk about that briefly later. But you can see there are a variety of formulations in there. There are also a variety of dosages, so be careful, when you're talking to your doctor, be sure. And if you don't know, bring your pills with you, the bottles, so they know, but make sure you know what you're taking, because there are a variety of formulations that they're not equal. So there are a lot of myths about levodopa out there. So levodopa came out in 1867, and it was used very, very widely. And people started noticing some problems, or just talk about in a bit, like wearing off, like things, it's not working as well, I need higher doses, and then things like dyskinesia, so abnormal movement. So people got very, very scared of this, and they developed this levodopa phobia. And that is still pervasive today, even with some doctors who are still, very reluctant to use this medication. So I do want to go over a few major myths, to clarify a few things. So myth number one, levodopa only works for a certain number of years, and I should save it until I really need it. So levodopa actually works for decades, and for certain symptoms, they'll work throughout the entire disease. So higher doses and or more frequent dosing may be required over time, but this is due to progression of disease rather than loss of efficacy. And so you can think about, when it's a progressive disorder, so when you're diagnosed, you still have your own cells. It's not like they all die at the same time. So you still have your own cells, they're still metabolizing dopamine, you're still creating dopamine, but over time you have less and less of those cells, so you need to increase, more and more supplementation. The other thing is, so it does not treat all the symptoms of Parkinson's, and certain symptoms become less responsive. But again, this is probably due to disease progression rather than actually losing efficacy. So one of our colleagues used to say, you can think of it as a car, right? And levodopa is gas, so you need gas to have the car run, but over time, other parts of the car break down, and no matter how much gas you put into it, it's not going to go. Another myth people are really scared about is that like levodopa will inevitably cause dyskinesia. So there's involuntary movements that patients, that I think Michael J. Fox is the most prominent person out there, and he has a lot of those dyskinesias. So fact is, it is true, there's a high risk of dyskinesia. About 50% of patients will develop dyskinesias. The severity of the dyskinesias, however, vary from person to person. They can be as simple as some head bobbing, leg fidgeting, or can range to wild body movements that a lot of people see with it. And when we come across that, there are various ways we can tackle it. While the drug, we can reduce the drug medication, we can add other medications to control it. There are other variety of techniques we do to manage them, but not everyone will get them. Not everyone will be very severe, and when we deal with it, there are ways to manage it. Another myth that's prominent is levodopa is toxic and will hasten the progression of disease. Fact is, levodopa has been proven to be a safe and effective medication. Like we said, it's a common amino acid that we all need and take in because we all need dopamine. So there's been no scientific evidence to support any claims of toxicity. And while levodopa does not slow down the disease either, studies do show it improves the quality of life. Furthermore, if it can help you move better and exercise, which does slow down the disease, then I think it's worth to take it.
So Yudhishthir Mahajan is your.
All right. So moving on, the next thing we're going to talk about are the drugs that mimic dopamine. So levodopa basically goes to what we call goes back into the cell in the substantia nigra, so it can be released in a controlled manner. And so drugs that mimic dopamine, they're actually they're just sort of attacking the cells without going through a packaging process, essentially. So these are things called dopamine agonists. So you may hear there's multiple of these drugs. These are ropinirole extended release, Mirapex extended release, the Nupro patch, and something called obiomorphine, which I'll talk about in a bit. So these are pretty effective medications. Again, not as good as levodopa. So you can use them. Typically, we don't like to use them in people over the age of 70, and I tend to avoid it even younger. Because over time, you know, when, like I said, back in 1967, when they found all these, back in the 70s, when they saw these problems with levodopa, they started using dopamine agonists and very prominently. And we've now noted that these medications have their own side effects, several of them, mainly a lot of psychiatric side effects. So impulsivity, sometimes can cause hallucinations. Sometimes, you know, they can cause excessive daytime sleepiness. So while I do tend to use them in more younger patients, you know, it's be aware of the side effects of these meds, because it can be quite disastrous. So, but they are effective, and you know, sometimes they have their role, especially early on in disease. The next class of medications, these are medications that help dopamine last longer. We already talked about carbidopa. So basically, these go after a variety of enzymes that break dopamine down. So you can think of these as battery extenders, and it could be dopamine you've taken in, like levodopa, or dopamine you already have. So these are kind of like, you know, if you have cell phones, you know, you have extra like batteries on the side. So that's kind of what these act like. So we talked about carbidopa. Then you have the so-called MAO-B inhibitors. These are Azalex, allegedly, and sulfonamide. You have to remember these medications. Again, if you don't remember the names, make sure you bring your bottles to your doctor. These are typically once to twice a day. They preserve dopamine that's already in your brain. Catecholamine or COMT inhibitors, things like Comtan, Tasmar, Ongentys, which is the newest one out. It just got approved this year. They basically slow down the breakdown of dopamine, mostly peripherally, so before it gets to the brain. Comtan and Tasmar are taken multiple times a day. The great thing about Ongentys, which just came out, is that it's once a day. And then the other new medication that came out, which was, I believe, is Norion's. It's called adenosine receptor antagonist. It's kind of an analog of caffeine. This came out last year, 2 years ago. It works on a whole different pathway, but also helps boost dopamine. It's also about once a day. All these medications, you know, I would call, they're probably equally efficacious. Just depends on, I think, the patient and how they, you know, how they feel and what they opt to try. On average, most of these studies, they improve, you know, what we call on time, or, you know, improve the boost the medication for about, you know, an hour to 90 minutes on average. Some people have more, some people have less, but that's about average. Then we have something called amantadine and anticholinergics. Again, these work on different chemicals trying to change the balance and therefore boost dopamine. Amantadine is not, you know, it's called an NMDA receptor antagonist. You don't have to remember that name, but the mechanism is not fully understood, but we know it does help promote dopamine and decreases another neurotransmitter called glutamate. And this can improve some motor symptoms like tremor, and can also improve, you know, dyskinesias. Immediate release amantadine is probably what most of you understand. Simitrel was the brand name. I think most people use generic now. They have the other two formulations out there are called amantadine ER, so Gocovri and Osmolex. So those are both extended release amantadine. Although honestly, amantadine is taken about once to twice a day on generally anyway. Another class is called anticholinergics. I'm not going to talk too much about these, but these are much older medications, something called benztropine and trihexyphenidyl. They basically decrease something called acetylcholine, which thereby boosts dopamine. These were the medications that were used before levodopa was on the market. Main problem with these is they can cause a lot of confusion. Adults really have a hard time tolerating it. They can cause cognitive slowing, dry mouth and constipation, all of which could already be a problem in Parkinson's. So then there's about 3 drugs, I call them rescue medications. So I don't know if anyone's heard about this. So rescue medications, so as your disease progresses, some of you may notice, oh, my medications aren't working as well. I feel off, or my symptoms have come back, or, it's before my next dose, and it's like an hour before my next dose, and all the efficacy of my medicine is gone, or suddenly it doesn't even kick in. So those are what we call like sudden offs, and this is like when we want to rescue like in between. So there are a variety of, there's 3 out there that's really for what we call rescue, although a lot of people will just take an extra dose of Cinemet or levodopa, which also works. But so there's the drug apomorphine that we talked about a few slides ago, which is a dopamine agonist. It comes in 2 forms. So one is the Apoquin pen, which is the apomorphine injection. So it's kind of like an insulin pen. You have to get the right dose, and once it has to be titrated correctly. Once you get the right dose, though, you just inject it into your knee when you're feeling off, and then it improves your symptoms in about an hour, so you can get your medications in, and so you can get moving again. They came out with a sublingual, so meaning you put it under your tongue, formulation, which was just approved this year. That's called Kinmobi, so that's in the middle here. Again, there are a variety of doses, and it has to be titrated correctly, but that's the sublingual form. If people don't like needles, that's out there now too. Then there's Ambrosia. I've had a lot of patients ask me about this. This is, again, for rescue, is not to replace your levodopa. It's Cinemet, essentially. It's levodopa. And what it is, it's a powder in a capsule in this little inhaler. You have to uncap the inhaler, put the capsule in, click the inhaler, and which bursts the capsule, and then you inhale the inhaler. You inhale the powder. You got to do this twice. It was only measured against placebo, so to me, it's levodopa, so it does work. Some people think it should be maybe because it bypasses the GI system, it gets there quicker. Again, it was never compared again to regular Cinemet, so science, we can't really definitively say that, but logically, it should work. Main issues, it will have all the same issues as levodopa, but I think the other problem is coughing. And the mechanism, usually people need a little help putting it together. So complementary treatment. So this is a big deal, I think, because the one thing we know that slows down Parkinson's is exercise. So physical therapy, I always promote physical therapy. It restores function, improves mobility, gives you strength, endurance, balance. And even if you think, well, I'm not getting better, it also, at least it'll help you keep status quo. Though I think it actually does help get better. There's occupational therapy, which helps more with fine motor movements. Speech therapy, a lot of people complain about soft voice. Medication doesn't really help that. The most important thing is really speech therapy. There's 2 big groups that have courses. So this is one, the Lee Silverman Voice Technique, and the other one is the Parkinson Voice Project. Swallowing therapy is important because your muscles are also used for swallowing, and these can cause problems over time, with choking or coughing. And no matter what you do, exercise, like I just said, is the only thing we know that slows down PD. Type is not as important as regularity, to do something you like, do something that you will keep doing. Those I will say, studies in animals show that some sort of cardiovascular does promote neuronal health, but again, that's in animals. So I would say use it or lose it. There are lots of programs out there that have blooms specifically for Parkinson's. Here are some examples, like Rock Steady Boxing, Dance for PD. The APD has Parkinson's training for fitness, health, and wellness. So, get out there, get moving. I'm going to talk briefly about some invasive treatments, but I think this will be in a later talk during the week. So there's surgical. So in terms of surgery, there's of course deep brain stimulation. I'm just going to briefly mention it. I know Dr. Fernandez will be talking about it. So it does not replace medications, but it can reduce them. It can help a lot. It doesn't slow the progression, but it can really offer and improve quality of life. It's not for everyone, but for the correct candidate, it can be an excellent treatment. Other surgical options include lesioning. So what's lesioning? Lesioning is a controlled destruction of an area of brain tissue. And there are a variety of ways to do it. The newest way is focused ultrasound. But basically, before DBS, that's what we used to do, is sort of do a fine destruction of a very small area, which helps improve symptoms. Then there's continuous levodopa therapy. The only one out there in the market right now is Duopa. So what is Duopa? Duopa is an enteral suspension of carbidopa levodopa. So it's a carbilevodopa gel. It's pumped directly into the small intestines via a J tube and allows for a fine control of levodopa dosage to avoid dyskinesias. And because it's continuous, it treats motor fluctuations of the on and off. So here you can see a schematic on the top left, bypassing the stomach and going directly into the intestine. This is the site, and here on the bottom, you see a person actually with it. This is the size of the pump. And here you see the J tube. So it's effective. It's really not the most cosmetically pleasing, but it does work. But you do need a tube to connect the medications to your intestine. So non-motor symptoms, or we talk a lot about non-motor symptoms. So this is just a refresher of what we talked about, a variety of non-motor symptoms, anywhere from psychiatric to autonomic, like I said, the autonomic system. So again, very multi-system disease here. We don't really have any specific non-motor treatments except for Parkinson's hallucinations. So about 20 to 40% of patients experience hallucinations at some point during the course of disease. The severity varies. They may be minor illusions, meaning they think like a tree is a person, or something's moved across their corner of their eye, or they could be fully formed figures, voices, sensations. So there's a big spectrum of what's called Parkinson hallucinations. The statistics that people quote, also includes episodes of delirium. So what's delirium? Delirium is usually like when you are acutely ill and you're in the hospital and you're seeing things. So, or it's due to a medication, something like that. So that just means it's waxing and waning. It's not there permanently. Pimavanserin, aka Nuplazid, was approved in the FDA in 2016 specifically for treatment of PD psychosis. Prior to that, quetiapine or Seroquel was used, and it's still frequently used. Quetiapine tends to work faster, though there's not as much evidence supporting it as pimavanserin. And the reason I wanted to bring this up and talk about it is that I know pimavanserin has a lot of television ads out there, and people can be frightened about it. It's like, oh my God, I'm going to get hallucinations. But like I said, it's not. It really varies, and sometimes it's just due to a hospital stay or a medication. But I did want to mention this because this is the only one where we have only non-motor symptoms where we have a PD specific treatment for it. So like I just said, so if you have other problems, we still treat it as we would if someone didn't have Parkinson's. So if you had depression, we treat it with antidepressants. If you had anxiety, we treat it with anxiolytics. Constipation, we were going to treat your constipation. Especially, so if these symptoms become problematic, we still want it to be treated, just as you would your motor symptoms. So let's talk about management. So who do you see, right? So first of all, your diagnosis should be made by a neurologist, preferably, I'm biased of course, a subspecialist in movement disorders. There should also be the person continue Parkinson's care. The reason I say at least a neurologist or even a movement disorder is that there are things that look like Parkinson's or have Parkinsonian symptoms, but aren't Parkinson's. And sometimes, if you don't fit that classic picture, someone just calls you Parkinson's, and that may or may not be the correct diagnosis. Movement disorder specialists or neurologists that focus specifically on conditions that affect movement, like Parkinson's. We have gone through extra training exclusively concentrating on patients like you. That being said, like I said multiple times, it is a multi-system disease and should have multidisciplinary approach. So sometimes I'll refer to a cardiologist to help manage the blood pressure. If it's also waxing and waning, if there's a lot of, depression or apathy, or fatigues, I'll talk to, or hallucinations are really difficult to control. I ask them to see a psychiatrist. Urology, sometimes waking up multiple times a night, going to the bathroom, I sometimes ask them to see a urologist. Sometimes constipation just becomes very out of control, so you see a GI person. You should always have a primary care. I'm a neurologist. I was trained in neurology. I have Bronson, but in terms of primary care, I may not know like what's the most effective treatment, for blood pressure issues still, or if you happen to have an infection, I don't know what the correct antibiotic is because I haven't been doing medicine in many, many years. So always have a primary care to assist, coordinating your care. And like I said, physical therapy, occupational therapy, speech, swallow, these people are also very, very important. So how to talk to your doctor. So Parkinson's is a complex disease. Make sure you note your motor and non-motor symptoms, whether or not you think it's related to Parkinson's. Many symptoms can be, however, multifactorial, meaning it could be multiple reasons, not just PD. So take note of other changes in your health and your life. When discussing your medications, note your side effects and benefits, but also how your symptoms, both motor or non-motor, vary through the day and vary with medications. If you're comfortable with it, also bring your partner, friend, or family to your appointments that they may notice some things that you don't. And also I'd say, if you don't know the names of your meds, bring your meds in the bottles to your appointment. So support, safety, and independence. So I know it's hard right now because it's COVID, but it's important for you to form a community because, again, we're not the ones experiencing it. You are. I may know the science, but I don't know what you're living through. So I always encourage joining support groups or having friends, patients, and for caregivers. Exercise, again, it promotes independence and quality of life. Group exercise programs can promote this and socialization. Don't be afraid to seek out a therapist or psychiatrist if you're having difficulty. I know mental health has a big stigma, but it's important. It's very important, and your mental symptoms can affect your physical symptoms. Getting out is good for you. Again, I know it's COVID right now, which is a little bit difficult, but try and maintain your relationships and friendships. Even if you're retired, try having a regular schedule. It can help maintain your mind and your function. Safety at home. If you need a walker or cane, use it. It's not about becoming, I would rather you be moving with a walker rather than sitting all day. People ask about driving. I think there are independent driving assessments. I always recommend patients, if there's a concern, to go use them. You don't want your doctor or your family to be a bad guy in this, all right? So take home message, Parkinson's is a complex and multi-system disorder that is chronic and progressive, but everyone is different. Dr. Schneider, who was a physician at Robert Johnson, he said, there's no Parkinson's disease, there's Parkinson's diseases. Though there is no cure, there are many treatments available and more coming down the pipeline, which Dr. Meridian will talk about tomorrow. Talk to your providers. You're not alone. Ask for help if you need it. You're not your disease. You have PD, but it doesn't own you. Okay. So, despite the technical difficulties, I'll here to answer any questions you may have. I'm going to stop sharing, and I'll give it back to Sheila.
Okay. So what I did was I just made a Word document of the questions for today. So I'm going to share my screen for you to see the questions. So you could, instead of me just saying them to you, might be easier. Okay, those are the questions. Can you see them?
Yeah, it's a little small. Okay, so number one, is there a substantial difference between cinema ER and right tire? Are they essentially exchangeable? No, they are not exchangeable. They are very different. So Cinema ER was an old version of an extended release, and I actually have a patient who worked on it, and he says it's terrible. But for some people it works fine. So cinema ER, it's very slowly released. So for a lot of people, it doesn't give that kick in that they need. And a lot of times they will need a Cinemat with it. Rytary is actually a capsule, and it's made with little beads, a variety of releases. So there's some immediate release, there's some intermediate release, and there's some longer release. So it's a combination of a different groups of length of how things last. So they are not interchangeable. And other times, what a lot of new practitioners want to do is they try to convert people from Cinemat or regular carbilevodopa to Rytary, and they don't read the instructions. They are not one-to-one. Rytary has multiple dosages, and one Rytary does not equal one Cinemat. So I would say it's a little bit hard sometimes to really convert. So you have to do it, sometimes you do slowly, or if you completely convert it per the company's conversion chart, sometimes there's a lot of back and forth trying to figure out, oh, what's the right dosage. So long story, they're not interchangeable, and one Rytary does not equal one regular levodopa or Cinemat. Is there any work being done to examine brain tissue for levodopa in living patients? No, we don't get brain tissue because it's going through a surgery, and we don't want to damage anything we don't need to. I mean, we certainly encourage people, if they want to donate their brain to study Parkinson's, that would be great. But it doesn't help us to look at the Lewy body. People are looking for ways to use nuclear scans specifically toward Lewy bodies, so the alpha-synuclein. So that is being looked at. So because some other neurodegenerative diseases like Alzheimer's have a different protein involved called tau or amyloid. So they're then sometimes they overlap. So they are looking for other nuclear isotopes to identify them. I was told I should not take carbidopa late at night. Is this true? And if so, what time should the last dose be? So that all depends. Because the medication is supposed to help you move, I generally recommend not taking it at night because you're sleeping. However, if you are having a lot of difficulty moving in bed, or your tremor is keeping you up and you're not getting comfortable, or overnight, like you need to use the bathroom, it's really hard to move around. In those cases, I say go ahead and take something at bedtime so that you have a little something in your system. Generally, when you're taking what time your last dose should be, it depends what your previous dose was. I usually recommend you just keep a regular interval as best you can, how many times a day you're doing it. If you're taking it 3 times a day, you're up at 8, so take one at 8, take one at 1, 7, something like that, something regular. Varies for everybody actually. So anyway, I would say it varies on how much you're taking, how much you're needing, whether you're not having wearing off. There's no ideal time your last dose be. That really depends on your symptoms. Post DBS surgery in June. Post DBS surgery in June 2020, I not only had greater control of my PD motor issue, left-hand tremor, and freezing of gait, but I also had dramatic improvement in acuity and energy. Excellent. I know that DBS addresses motor issues. Do you think improvement in acuity and energy was DBS related, or more likely to reduction of my medications? I went from 10 Cinemat a day to 4 Rytary a day. I can't really answer that question. I know some people certainly experience improvement in their non-motor issues after DBS. The reason I say I can't guarantee any of this is because that's just what the scientific studies show. We know it improves motor symptoms. How much it improves non-motor symptoms varies patient to patient. Is it really maybe a reduction of medications? It's possible, but the opposite has happened where patients reduce their medications and their motor symptoms were better, and some of their non-motor symptoms got worse. So it's hard for me to say on that one, but I'm glad whatever the reason that you've improved. Does carbidopa, levodopa need to be taken alone? Can I be taking other things? Keppra, how about with the supplements? You can take it with anything. Doesn't really interfere. Again, it's levodopa. We take it in our everyday meals. The one thing I would say is a lot of people ask about, should I take it with food? Should I not take it with food? So technically speaking, when you take it, it does compete with other protein absorption. So if you can avoid protein, that'd be great, but not everyone is as sensitive to it as people. So I never say it's a hard rule that you have to avoid meals with it. Sometimes later on in the disease, people get more sensitive to it. So they hear about dose failures that it doesn't kick in. So in those cases, that's the first thing I'll recommend is maybe try to avoid meals, but it's not absolutely necessary. And you can take it with Advil, Tylenol, Keppra, it doesn't interact. And that answers question 6. Should 3 doses be used evenly, or it doesn't matter that much? I usually say spread it out evenly if you can, because that's what it was marketed as 3 times a day. But usually early on the disease, some patients don't notice, obviously they don't notice they're wearing off. We don't know exactly where you are in the disease or how progressive it is. So usually what I recommend is just keep it even so that what you can tell, if you're taking it sporadically, you may not know if it's working or not. So try to spread out evenly. It's just easier for you to keep track of your symptoms. I am taking both levodopa and pramipexole. Can I wean off pramipexole IMR? This is something discussed with your primary care, whoever is managing it. You can wean off of it. The dopamine agonists tend to, not everyone experiences this, but tend to be sometimes hard to come off because you can experience withdrawal from them. So you can wean off of it. Just do it on, talk to your doctor about it and work on a plan from there. You may come off of it and realize maybe I need a little more levodopa when it's unclear, and it depends how much you're taking. But definitely talk to your neurologist about that and have a discussion with them. Husband experiencing full body shaking nervousness and very anxious. Eye problems coming down. What can be done? This is something to discuss with your neurologist specifically. If it's anxiety related, then maybe something needs to be done for whether your anxiety medication or an antidepressant. And I would say antidepressants actually work as both anxiety medication and antidepressant medication. A lot of people associate like Xanax or clonazepam, Klonopin, Ativan. Those are anti-anxiety. They're more like Band-Aids. So that's something like drinking a glass of wine because I'm really nervous. That's what it does. You need something to actually calm the underlying issue. So those would be things like Zoloft or Lexapro. So sometimes that's needed as well. And if some of those things it becomes too complicated, I usually recommend you see a psychiatrist. We have a very good one who works with dementia patients and Parkinson patients. Does appearance of certain symptoms indicate progression of the disease, fatigue, drooling? It's not necessarily specific, like one type or the other. It's hard to say. I wouldn't say drooling or fatigue, is it? Certainly requiring a little bit more medication for your motor symptoms, falls. So it's hard to answer that question. So it's like what means progression of disease. Usually you're the best judge of that. I usually tell patients the last 3 years are going to predict your next 3 years. I would say certainly changes in your motor symptoms, walking becoming an issue, more of an issue, that certainly is a sense of progressing disease. Some of the autonomic symptoms, yes and no. I had some patients that got the low blood pressure dropping early on, but once that was controlled, the rest of their motor symptoms were pretty stable. So it's hard to use, especially non-motor symptoms, as a judge of a progression of disease. Certainly the more cognitive changes probably could be more sign of progression, but it's hard to be very specific. Supplements like B-complex, B12, D3, omega probiotics. I think they have some evidence for other diseases. I think probiotics are good for constipation. I don't think there's anything wrong with taking supplements. I think like D3 and vitamin K, if you have osteopenia, like low blood bone density, something you should take. Omega, if you have, high cholesterol, it's been shown to those. And I don't think any of those are specific to PD, but they're good supplements. I know people take turmeric, which is fine, glutathione. A lot of these things have some basis in molecular studies in Parkinson's, but how much actually gets into your brain, that's less known. Oh, I just wanted to use a vanilla extract as an explanation of like pure levodopa versus something that imitates it. So dopamine versus dopamine agonists. I'll take that off, it's confusing. Let's see, what else? My husband is constantly getting bed sores. He knows very little what I can do. Had him schedule physical therapy. I cannot get him to go. How to, what this is. Well, so I do say motor-wise, is it motor when you're getting less mobile, that is a sign of progression of disease, and but sometimes if it's not motivated, it's hard. I feel for you. It's hard to force someone to do that they don't want to do. Yeah, it's just about motivation. Sometimes people need a little motivator. Sometimes they have medication. And it's hard. I think it's something you should discuss with your doctor. In terms of the bed stores, just make sure they're clean. And if he won't, move, then get some help. Make sure he's not staying in one position for a long period of time. To go, how do we know? So, I mean, the fact that depends if he's falling or not. I'm not sure. So, I think that would take more of a unique, tailored consultation. Some research shows iron supplements can interrupt absorption. How do you separate the time between the dosing? Yeah, so iron can worsen constipation, so I would just separate it by 2 hours if you can. Constant drooling, how do we deal with it? So usually the drooling, so you can take some medications, but again, the medications can cause side effects. So those are things that we call anticholinergics, and it can cause that. One of the side effects is dry mouth, but usually what we do is we inject something called botulinum toxin. People understand that as Botox. So we inject it just to decrease the amount of saliva production. So that's usually what we do. It's very safe. It's like a 2-minute procedure in the office. 3D brain scans, I'm not sure. Do we do 3D brain scans? I'm not quite sure I understand this question. Like I don't think there's really, I mean, there are studies that look at specifically the tracks. I mean, like the white matter tracks, and they can look 3D. A lot of this is mostly currently in research. If you're interested in imaging studies, you can look at, let's see, who usually does a lot of them. I think Long Island, so Northwell, I know several, Northwell Health in Long Island. There's a big imaging guy in Parkinson's there. You can check out if they're having any imaging studies. But if you're interested in study participation, I usually recommend going to clinicaltrials.gov and typing in Parkinson's, and they'll help you, look at what's going on around the country. So that's where the national database is. You can also look into the Michael J. Fox Parkinson Foundation, APDA. They usually keep a list of current research, but clinicaltrials.gov, that's the big database for the nation. So if you just type in Parkinson's, and it'll come up. It's worldwide, actually. How does PD affect bowel movements and what degree? It causes a lot of constipation. Again, it varies patient to patient. Some are severe enough that I need to refer to a GI specialist, need to be on more advanced meds. Some people just need diet changes. Some people just need a Miralax every other day. It varies. But it can affect the GI. It can also not just affect the large bowel, but it can also affect, how fast things are absorbed. So there's something called gastroparesis, where the stomach doesn't move and people get bloated very easily. Again, this is usually when I refer to a GI specialist to help get it. It can, this also occurs in diabetes. I understand mannitol increases the efficacy of levodopa as it opens up the blood-brain barrier. I have not found in studies that mannitol does this. Mannitol is used when there's increased, it's used when there's increased intracranial pressure, and it's used for the neuro ICU for people who have swelling in the brain. So what they're trying to do is basically diurese really quickly. So I have not heard that opens up the blood-brain barrier. If anything, it just diureses and everything comes out. So because this is a medication specifically used to decrease intracranial, when the brain starts to swell and it's becoming dangerous, that you can almost, the brain is a box. So if it swells too much, you can herniate and you're basically breaking your brain stem. Let's see. Besides exercise, will the president discuss diet, food, eat, avoid, use, any impact on diet supplements of Parkinson's disease? So like I said, exercise is the only thing we really know for sure, but there's a lot of studies going to the Mediterranean diet. So there is some scientific evidence for like the Mediterranean diet to help with Parkinson's and changes the gut bacterial makeup. And we are doing studies, and even where we're just looking at certain supplements that can change what we call microbiome. So your gut actually has its own flora, like microorganisms that help regulate. So we are looking into that to see if we can change it to make it look more normal, to see if we can improve Parkinson's disease. So that's being looked into very specifically. But right now, for sure, the Mediterranean diet is being looked into, and that does have some evidence for it. Let's see. I seem to have more dermatological problems now, little cuts that get infected. How can I confirm my resolution? I'm not a dermatologist, so I don't really know. I do know there are some dermatologic problems in Parkinson's, like there's something called seborrheic dermatitis. That's a big thing. Which is essentially what causes dandruff and skin itchiness. So that I know is associated with Parkinson's. And it can, because of the affecting me. But I'm not a dermatologist. I can't really, clarify on that. So Mucuna pruriens, like I said before, it has a strong percentage of levodopa, but it's still, even when I say there's a big percentage, it's like 6%. Compared to a pill, which is like 100%. So I've had patients who try to use just the tea, but they end up going back on levodopa. There's usually not enough in there to really treat your motor symptoms. And again, it doesn't do anything to slow down the disease. If your medication is making you sleepy, is there anything to help this, or just normal thing to take a nap? Yeah, that's a good question. Is there any specific? Not really. Have a little coffee, take a nap. Some people do feel it kind of, make them tired, then they perk up afterwards. And some people notice that they feel sleepy when the medications wear off. So it's hard to say, but if it is making you sleepy, I don't think there's anything specific, except, I think just take a nap, drink some coffee. Help with frequent urination. I usually recommend you talk to a urologist. They have a variety of medications that they use. There's nothing specific to Parkinson's. There are a variety. You can try things like trospium or Betric. I know oxybutynin was a very old medication that constantly used. Really severe cases, they sometimes will inject a little bit of Botox into the bladder if it's due to overactive bladder, just to try and slow it down. Of course, the main side effect of that is urinary retention. So I would recommend you see a urologist about that. I have DBS and my skin itches. I tend to scratch during my sleep. It bleeds and then not heal. I I guess you could try and keep it covered to avoid scratching it. I think there are certain types of topical agents that can decrease the itchiness. I would also discuss it with your surgeon to see if there's anything, but generally maybe make sure it's covered so you're not tempted to go after it. Sleeping during the day and up all night is common in Parkinson's disease. The side effect measures. It's probably common to Parkinson's disease. It's common to aging as well and dementia. So there's a lot of changes in your sleep cycle to do that. Things to help that are, making sure that, so we do know that there are changes in your sleep cycle, changes in your melatonin level in Parkinson's disease. Things to help or make sure during the day you expose to as much sunlight as possible to reassure your brain this is daytime, I'm supposed to be wide awake, be active and exercise. All those things are can help out with that. Sometimes melatonin can help try and regulate your sleep cycle as well, but it is very common to Parkinson's, to Alzheimer's, to age, I would say. Is that everything?
That is
Sorry
all
if
that I
something.
have right now.
Sorry if some of them weren't the best answers you have. But that's what I got. That's what I have.
So I appreciate you, Dr. Chen, for joining us today. And I appreciate everyone for joining us today. If you had any technical difficulties on your end that you would like to clear up before tomorrow, please send me an email and I'll try and help you resolve it. Otherwise, that's it for today. And we'll see everyone back at 1 o'clock if you're joining tomorrow.
Just one last question, I guess.
Oh.
Any specific exercise you should be in long walks except for satisfactory, or should we do something more rigorous? Do something that makes your heart rate go up a little bit. That's what I would recommend. But good long walks I think is good too, though. Just anything that keeps you moving, what you like to do. If you don't like boxing, don't go to rock steady boxing. If you don't like dancing, go to
cardio.
If you need the exercise, please send me an email. I'll send you some exercise programs.
Try rock steady boxing.
It's fantastic, right?
Yeah.
It's changed my life.
All right. Great. It's good to see everyone. Take care. Let Lucia know if you have any further questions. Can you see this video game? It's not.
Yes, I have it recorded. I'm going to be recording most of the sessions this week, except for tomorrow's won't be recorded. But I will, if you reach out to me Friday or maybe early next week, I'll be able to send you the recording.
Thank you.
You're welcome.
Thank you, Dr. Chen.
Thank
No problem.
you.
Take care.
All right. Have a good
Thank
day,
you, Dr.
everybody.
Chen.
Thank you, Doctor.
Thank you.
Everyone.
Bye-bye.
Bye.
She is a scientist. She just got a grant to continue with her work in a lab studying
Thank you.
So the group meetings, support group stuff.
I don't know why you don't want to hear that.